thank you very much for the invitation to this wonderful debate. I am a big fan of the work of Belinda Lennox, who I think will be speaking later. So I am looking forward for this conversation, which I entitled Phenomenological Psychopathology in Clinical Neuropsychiatry, Insights into Psychosis. And I will start with the question itself. Psychosis as a psychiatric or as a neurological diagnosis? This is the first question, of course. So perhaps in a sense, it's related to a larger philosophical problem, the mind-body problem. I will just show one slide on that problem, although many of you are perfectly aware of this problem. And I will try to go through more specific problems, which is the problem of consciousness, because phenomenological psychopathology is really a tradition about the knowledge of human consciousness in the clinical field. So, I'm sorry. But then I will try to go into a more specific field, which is the field of autoimmune psychosis, because I want to align with the topic of the next talks. So my question will be if a phenomenological approach is useful or a cognitive neuropsychiatry approach, or both. So about the so-called mind-body problem. Of course, this is a philosophical question, not a clinical question, but in a way, neuropsychiatrists deal with this problem on a pragmatic fashion every day. Now, this slide is from Tuomas Pärnu, a philosopher from Finland, I think, and the article is dedicated to the 5 marks of the mental. Now, I will not deal with all of them, of course, but only with the problem of consciousness, specifically the concept of access consciousness versus phenomenal consciousness. I think it's important for us in neuropsychiatry, and perhaps the question of semantic content. Now, starting with the problem of consciousness, as we assess consciousness in our patients, we need to assess the content, the mental content, the subjective experience of our patients, whether it's a neurological or a psychiatric case. But first, we must assess the general level of consciousness in our patient, the level of alertness, if you will. So on the left side of the slide, you can see a case of a person with a permanent vegetative state, and on the right, you can see a patient with a minimally conscious state. Now, these problems allow us to make a sort of breakdown, a conceptual and operational breakdown between the problem of subjective consciousness, of subjective awareness and subjective experience on one hand, and on the other hand, the problem of wakefulness and alertness. Because the patients with permanent vegetative state have a preserved wakefulness, but not the features of alertness, which is responsiveness. I mean, having a specific response to a specific stimuli, and they apparently don't have at least features of subjective experience, which are a little bit more preserved in case of minimally conscious state. Now, going from wakefulness into consciousness as such, I think that some of the cases we treat are interesting to illuminate the problem of access consciousness, which is this distinction, you know, by the philosopher Ned Block. So he divides phenomenal conscious, which is the feeling, the awareness of in the context of experience, as contrasted to access consciousness, in which I illustrate here by a case of Anton syndrome. So as you remember, in Anton syndrome, the patient is blind, but he's not aware that he or she is blind. So there is a problem with access consciousness, in my view. Even when the patient is awake and has features of alertness, but their subjective experience is, has this problem of access consciousness, specifically to the instances of visual awareness. Now, moving on to the problem of psychosis, I think we deal here with a more complex problem, which is phenomenal experience as such, and the difficulties of our patients to translate their subjective experience into a format of linguistic communication. So, for instance, this is the discourse of one of my patients. No? He says, "I am Marco Antonio. I died when I was still a baby. My soul was absorbed, and then all this human physiognomy began. I became a phytocultivator. What's that human physiognomy mean? Well, basically, a healing machine, a torture machine. I am now an object of torture," and so on. So, this is the problem that we need to deal with when we go into the field of psychosis. So I would like to clarify what are the features that we will try to capture in the field of psychopathology. So I think that we need, for this problem, three approaches. The first one is descriptive psychopathology. And descriptive psychopathology, in my view, requires a narrative account, a narrative account of the history of the case, of the history of the illness, a phenomenological interview that tries to capture the first-person perspective of the patient, and clinimetric tools, whenever possible. Now, following the advice of Dr. David and Dr. Halligan in this famous article, Cognitive Neuropsychiatry Approach to Psychosis, we in the clinic try to make this other approach, a neuropsychological approach. I think it's essential in psychosis to understand what are the cognitive features of the case. And we like to do an hypothesis-driven cognitive assessment, not a general, non-specific cognitive assessment, but hypothesis-driven cognitive assessment. And finally, we make some tests, neurological tests like laboratory, brain imaging, electrophysiology, and most importantly, a neurological examination. I already pointed out in the previous talk that perhaps not all patients require this kind of very demanding approach, but only patients with red flags, right? Patients with red flags. To me, patients without red flags perhaps need some essential screening tests, but not all of the tests. Now, instead of thinking of neurological versus psychiatric features like being mutually exclusive, I already pointed out that to me, the psychiatric features are more like descriptive features of the psychopathological pattern. Sometimes we can point out to specific etiological agents within psychiatry, like in the case of post-traumatic stress disorder. But sometimes I would think of primary psychiatric disorders as being idiopathic for the moment. No? Sometimes we can make a compelling psychological story, and sometimes we can't. But we can always point out at the psychopathological pattern. In that sense, psychosis to me is always psychiatric, not because there is an essence, a psychiatric essence, but in the sense that we need to always specify the psychopathological pattern, of hallucinations, delusions, disordered thinking, and so on. So to me, psychosis is a syndromic or syndromatic diagnosis that sometimes progresses to stage 4 or stage 5 and sometimes remains in stage 3 of this presentation. Now, this is a case to make an example of the cases in which we do have a biological marker. This is a case we worked out with Dr. Pollack here, in which the features of phenomenologically, this patient has a Capgras syndrome. He doesn't have seizures, he doesn't have even catatonia, he does have a severe case of cognitive disturbance. He doesn't have dyskinesia or other features of a neurological case, but he has red flags, and the diagnostic tests, like the PET imaging, shows the specific markers that we require to search for the antibodies. So the patient has NMDA receptor antibodies, and he has a bad response to antipsychotics, but a very good response to immunotherapy. Now, let's look at a different case. This person, in this other case, we also have a patient with Capgras syndrome, but here we don't have any specific marker, a biomarker that could lead us to a specific neurological etiology. We only have the psychopathology. So this is a case of Mrs. G, who reported that her children had been kidnapped and that the persons living with her are in fact their doubles. The imposters also are kidnapped victims who had their memories erased and an electronic device implanted, which is why she tries to get along with them. The kidnappers also implanted a chip in her, so through which they can alter her perception of reality and in turn make her real children present themselves looking like strangers. So it's a case of Capgras. But it's also a case of Fregoli, because she claims that several customers at her shop are in fact their children, who ask a series of questions disguised with other words as a way of testing her. Mrs. G must answer in a specific order to these questions to recover her family. Due to the undercover nature of the questions, she never manages to answer them correctly. Now, the technological devices that we use didn't show us a specific etiology. It is a case of schizophrenia, if you will. However, the cognitive assessment points out to abnormalities in self-directed signaling with perseverative answers. And this is taken as a proxy for an abnormality in the sense of familiarity. So this would be the road that we would like to transit for an explanation of the case. But it's an explanation at the level of cognitive psychology, if you will. It is not a full explanation of the etiology in this case. Now, here's another case. Here we do have specific features of autoimmune encephalitis. This is a patient with a Cotard syndrome. He started with a lot of somatic symptoms. He was even rejected in my hospital and sent to a general hospital because he was complaining of different somatic symptoms, but they were the prodromal phase of a case of autoimmune encephalitis, specifically with a Cotard syndrome. So the patient had the delusion of being dead. Now, the markers shows us in this case, along with the antibodies, they show us a very important hypermetabolism in the frontal and temporal lobes before the treatment. After the treatment, she has a complete recovery, as you can see on the right side of the slide. And you can see also that the features of hypometabolism in the occipital lobe also recovered completely. So this is, I would say, a case of neurological psychosis, if you will. Although the psychopathological level of description is similar in a way to cases with primary psychosis. Now, as an explanation, I use here this work by Lisa Feldman Barrett, in which she was able to study many cases of healthy subjects to obtain the markers of interoception that I think would be a very important feature leading to, in this case, the delusion of being dead, the Cotard's delusion. So what we're using today on the pragmatic side to capture these cases is the proposed criteria for autoimmune psychosis, especially this criteria for possible autoimmune psychosis are very helpful for us, because on one hand we can try to test all patients with psychosis, but apparently the efficacy of that measure is very low. Many patients without red flags will be negative regarding the antibodies. But when we use this specific criteria, like the catatonia or the severe and disproportionate cognitive dysfunction, which I tried to show in the previous talk some data on that, that increases significantly the likelihood to find a case of autoimmune psychosis. Now, I am going to show you one of the cases that have been controversial in my own hospital, and then even by trying to publish this case, well, it says on the review, but fortunately yesterday I received the letter of, that it was accepted, but we had to make a strong discussion with a reviewer that was extremely skeptical. So let me show you the case, and then I'll show you the discussion. So this is the patient before immunotherapy. She spent like 3 months with this severe form of psychotic depression with a lot of somatic symptoms, and specifically with a lot of nihilistic delusions. This is after the immunotherapy, but before ECT. Now, in this patient, we have the features of neuropsychiatric lupus, but there was still some doubts that it would be really a case of neuropsychiatric lupus or just a case of primary psychosis. Because as known, in lupus, we don't have a marker that could lead us to a definite diagnosis. The best markers that we have, as far as I know, only increase the likelihood, like the P-ribosomal antibodies, that she has positive in cerebrospinal fluid, but that didn't convince my reviewer. So, well, you can see it's an immense suffering in these cases, one of the cases which I suffered the most just by being with her. And this is after the ECT, no? She had a remarkable improvement in most features, even cognition, and she recovered completely from the psychotic phase. Now, the question for me would be, if we did the immunotherapy and then we did the ECT, would ECT be enough in this case, or would it be necessary to do first the immunotherapy? Because in a way, the reviewer is right to be skeptical, because if it was a case of autoimmune psychosis, why didn't it improve completely with the immunotherapy? Right? That is an important question. Now, let's look at the features in the brain imaging studies. So in the MRI, it doesn't give us a clue. It's broadly normal. It has some small hyperintensities in the MRI, but not enough to call it vasculitis or something like that. And the PET scan is clearly abnormal, but we had to use this comparative image from a healthy subject so that the reviewer could have the chance to see how abnormal it is. No? It has these features of an abnormal anterior-posterior gradient. There is occipital hypometabolism. There is a severe frontal hypermetabolism. And you can compare here the image, the axial projection of the patient, and below the features of a healthy subject. And this is not enough for my reviewer. No? So what I do next is, besides the value of the antibodies, the anti-P ribosomal antibodies, which increase the likelihood, we use these rating scales, these instruments, to measure the activity of the lupus. So we try to demonstrate that the psychotic depression appears in the context of activity of the underlying rheumatologic disease. And this apparently is compelling for the reviewer, so he accepts the paper. But myself, I regard a little skeptical, because I think that even in these cases, we don't have a definitive proof. I think we have it in the context, for instance, of anti-NMDA receptor encephalitis, or we have it, of course, in the context of neurodegenerative disease. But there are many cases, boundary cases, where we, myself, I don't regret doing first the immunotherapy because I think it was necessary to achieve the remission. Now, going to a larger case series, you can see here 183 patients of autoimmune psychosis from our sample, where, well, at least after making the study, 157 fulfilled the criteria for autoimmune origin. Most of the cases were anti-NMDA receptor encephalitis, some were lupus, and some other antibodies, and some non-specified. Some received antipsychotic treatment before, and this is an important feature because the patient didn't improve with antipsychotics. So to me, this is very important. They didn't improve, and some even appeared to be worse. Now, we did a recent paper with Thomas Pollack on antipsychotics and NMDA, and some patients will have the features of neuroleptic malignant syndrome. Although, it must be said that when we compare those patients with patients that did not receive antipsychotics, the patients that did not receive antipsychotics also had the features of neuroleptic malignant syndrome. So I don't think that there is enough evidence to say that there is a causal relationship between the antipsychotics and the features of neuroleptic malignant syndrome, but for the clinician, it will seem like it is the case, okay? So to me, if you see that the patient worsens after the antipsychotic, that is a red flag. Although at a scientific level, I'm not sure that that is the cause, that the patient is worsening. It might be just the evolution of the underlying immunological disease. Anyway, these are the treatments that we used, rituximab, cyclophosphamide. We always start with methylprednisolone, and this is the clinical change after treatment. So the patient improved significantly on the Rankin scale, on the Montreal Cognitive Test, on the Dimensional Psychosis Scale, on the Bush-Francis, on the Overt Agitation Scale, and in the Neuropsychiatric Inventory. There were large responses in all of those dimensions. Here you can see the features of psychosis. They were having a large improvement, except in the case of cognitive dysfunction. That is very important because here you can see the MoCA test. At admission, the largest proportion of cases were not even as evaluable, no? But there was an improvement, a clear improvement in the MoCA. But still, a large proportion of the cases remain with severe performances. So I would say that that is still the biggest problem to me with my patients with autoimmune encephalitis. This is another case in which you can see the phenomenology of the case. Once again, the patient provided, as the other patient, written informed consent for me to present this to you. The patient started with agitated catatonia, then orolingual dyskinesia. This is the phase of akinetic catatonia, or hypoactive.
¿No le salían las palabras?
No, no me salían.
¿Y el movimiento corporal
This is after
estaba
the treatment.
conservado o no lo podía hacer?
Sí, también.
Porque también había momentos en los que usted sí le han mostrado. ¿Quiere que le muestre un video?
Sí.
¿Quiere vernos un video de hace un par de semanas? ¿Sí recuerda esos momentos o no?
Sí.
¿Sí? ¿Y cómo se sentía en ese momento?
Que estaba muerta.
¿En ese momento se sentía eso?
Sí.
Ajá.
Y que no podía hablar.
Y que no podía hablar.
Sí.
¿Por eso estaba con la boca así abierta, como inmóvil?
Sí.
¿Sentía que su cuerpo no le obedecía en alguna forma?
Sí, que no me obedecía.
¿Y ahorita ya siente que su cuerpo le obedece?
Sí.
Como que ya responde a sus deseos, que está usted muerta.
No.
Siente que está viva.
Sí.
Y siente que vamos para adelante.
Sí.
So the patient has a significant recovery in most senses, except in the cognitive dimension where she still has some dysfunction, but she has a complete improvement. Interestingly, she can make a recollection of what was happening during the episode, but it is not a very clear recollection. She missed a lot of facts, perhaps, but she can even point out at this delusion of being dead that she described at the beginning of the episode. No? These are cases in which we don't have doubts of what's happening at the etiological level. At least we can say that it fulfills the criteria, the definite criteria of Dr. Grau's for anti-NMDA receptor encephalitis. Now, I don't think we have a theory of exactly what is happening in the patient, in the patient's brain or body, to explain the psychopathological features. To me, the results of the molecular imaging test give us some clues, perhaps, to understand these features of abnormal self-awareness in the case. But I don't even have an explanation of, in case they really have this pattern of metabolic dysfunction, I don't think we have even an explanation of why they should have that abnormal pattern, or what are the effects of the abnormal pattern. Looking at this study from Nature Neuroscience, I found out that apparently the highest concentration of NMDA receptors were precisely in the occipital medial part of the brain hemispheres. And of course, this is related with the brain rhythms related to consciousness. But more interestingly, these studies from Giulio Tononi show that, that those brain areas are activated during the conscious experience of dreaming, both in the REM phase or when those experiences of dreaming appear in the non-REM phases. Independently of the phase, if a phenomenological conscious experience appear during sleep, those areas will activate. So perhaps this is a way to approach the problem of consciousness. No? That's what I think. And it is consistent with most of the theories of consciousness that have been depicted recently by Dr. Anil Seth that regard this area as being very important. But finally, to me, the explanation of these problems requires a model that I am taking here from Uta Frith and Christopher Frith, from London, who make this very interesting approach that calls for two levels. An unconscious level of implicit metacognition, in which some basic mechanistic subpersonal processes are going on, and they're behind the making of the phenomenological experience. And once the phenomenological experience appears, so to speak, then the patient will have explicit metacognitive processes going on to make sense of that experience and giving to it a psychotic or delusional account or another kind of account, right? So finally, psychosis as a psychiatric or neurological diagnosis, to me, psychosis entails always the recognition of a psychopathological pattern. In that sense, it's always psychiatric. But it can be explained in a subset of patients by neuropathological patterns, although the causation process calls for a critical analysis. And I don't think we've finished the story, even in the more compelling cases. So to me, autoimmune psychosis is a model of the most compelling examples that allow us to recognize the value of empirical research. And some of the empirical research has been done around here. Thank you very much.
Thank you very much. That was amazing and thought-provoking as usual. So I think we'll probably take the majority of the questions at the end, but if there was someone with a burning question, we could maybe answer that now. One burning question just there. I'll take chairman's privilege to kind of divert it to the end, depending on what it is.
Very quickly, thank you so much. First of all, that's amazing. But you presented the consciousness or awareness issues as almost negative signs, you know, like a deficit that we need to find the cause of. But some of the psychiatric symptoms you're presenting can also be positive in the Jacksonian sense, like maybe they dreamt that they were dead, example, or, you know, kidnapped. So there's a positivity that sometimes a release of some meaning that could be explained by similar or different causes. Just the thought.
I completely agree. Perhaps we can make the discussion later on, but I agree that a Jacksonian model is very helpful in this case. I would still think that there are some levels of dysfunction leading to some levels of hyperfunction. And in fact, that's what the brain imaging shows, no? That there are areas of hypermetabolism and areas of hypometabolism. But yes, it is true that some patients will have an increased salience, for instance, no? A experience of salience related to delusions, for instance, mystical delusions or other kind of delusions. So yes, I think that a Jacksonian model is quite a very good model for this kind of cases. Thank you very much, Doctor.
Thank you.